Anyway, so the first point I want to make is that although professionals can help parents with their behaviour, the reason that this talk has the title it does is that ultimately it is parents, whether they are biological parents or not, or guardians or grandparents, it is the job of parenting, it's the people who are fulfilling the function of parenting who will solve these problems ultimately. And it can't be done without at least their involvement. And when people talk about behaviour, they sort of mean various things. And I'm only going to talk about the top two of this bullet pointed list. If you want to talk about how we help them with hyperactive behaviours, that's a discussion about at what point we make diagnosis of ADHD, and rigid behaviours, of course, in children who are anxious or have autism. Very happy to come back and talk about specific neurodevelopmental assessment and when and how we make diagnoses of conditions, but that's not my subject for today. I'm going to talk about oppositional defiant behaviours. I'm going to talk about violent and disruptive behaviours. Those are two different categories. Oppositional defiance, which I know is turned into a diagnosis, but it's not one that I use and I don't find it helpful, is basically, resistance to adult authority in some sense, whereas violence and disruption is kind of harm to others. So they are different in kind, and I think they're driven by different emotional substrates, really. Now, behavioural problems, I think behavioural problems and perhaps functional difficulties are two of the kind of heart sink things that you see. And I think sometimes we're kind of desperate to make a diagnosis because then we can say, oh, well, we're within our safe zone, we're within our comfort zone when we're talking about diagnosis and kind of being clever doctors. But actually, behavioural difficulties in themselves are really tough to talk about. And I think there's lots of reasons why that they are tough to talk about, which I want to just acknowledge and talk a little bit about now. The first is that the health service and the services generally are terribly set up for them. The health service, if you look at this little table, basically runs along this. Oh, by the way, just to confirm, you can see the arrow, my cursor. I think you usually can. They run from simple and common things. Primary care, complex rare things, tertiary care, and secondary care sort of in the middle. Simple and rare things that are simple are also dealt with by tertiary care because they're interesting, and tertiary care likes to see things that are interesting because they can. But the problem areas are things that are both common and complex. We're not good as a health service at dealing with that, and I think a lot of it gets dumped in primary care. And I think in community paediatrics, particularly, we can feel part of primary care sometimes, and we can therefore be swamped with a lot of these difficulties. Because they're the wrong sort of complex. We're very good in the health service also at this kind of complexity. This is a trilogy of fallow, so okay, fine, we've got, oh, this is complex. This is, this is something that we can throw lots of money at because it's medically complex, it's anatomically complex. We're also reasonably good at this kind of complexity. This is somebody in a wheelchair, but let's just say this is somebody with physical disability who has good mental health, has a supportive family, and is well set up. Actually, day to day, they're not complex, but they are regarded by the health service as having complex disability because they have an OT, a physio, and a paediatrician involved. So therefore, they're complex, and so therefore they attract money. These kids, who are the archetypal and perhaps stereotypical children with oppositional defiant behaviour, the hoodies, hanging around, the drinking Stella when they're clearly not 18. Those are the kids who are the stereotypical behavioural difficulty kids, and they are complex. There's no question. If you actually work with them, they're highly complex, but they don't attract any attention from any agencies as their complex children, as the children that they want to throw money at, partly because they're they cut across different agencies in terms of their needs, and partly because they're not that easy to treat and the outcomes are not that great. So your organisation doesn't necessarily look good if you take ownership of these children. There is a terrible lack of ownership of behavioural difficulties in the system as a whole, which we haven't managed to address. The other reason why I think they're difficult is that there's lots of poor, difficult, incorrect approaches. I'm going to point out 3 incorrect approaches that I don't think help, and then one that I think has the potential to help. So the first is the pure medical model, is the cutting up of people into categories, the labeling of a category, the explosion of different different diagnoses. And this is particularly prevalent, of course, in the US system, where you can be diagnosed with pediatric bipolar intermittent explosive disorder, and it very much treats the person as an organism without any context. It very much, obviously, particularly in the American context, biases you towards pharmacological solutions, and it doesn't necessarily give any hope of change. So one of the problems I have with oppositional defiant disorder as a diagnosis is that diagnosis is often very difficult to move on from. And if something is a situation, you've got into a pattern of behaviour, that feels more changeable than if you have a diagnosis and therefore that's you. And often, I think everyone's experience is that is pretty much the end of it. The second incorrect, I think, approach to behaviour is that all behaviour is caused by a discipline deficit, essentially, and that just more and more discipline, more and more rigid, consistent and firm discipline is all of these children need. And that's, again, a stereotype and of the kind of zero tolerance approach that schools do explicitly take to behaviour. And I think if that is taken without any appreciation for the differences between children and the differences between their responses to discipline, then that can be very unhelpful. Because again, if you don't respond to a disciplinary approach, then there's something wrong with you, because it's because your parents haven't brought you up properly, or because you're just not trying hard enough, and that obviously lets children down as well. And the third approach that I have to say I disagree with is the idea that all children's behavioural problems are because their families haven't paid them enough attention or haven't given them enough quality time. Undoubtedly, all of these elements, there is an element of truth to it, but the tendency that I have noted, particularly when a family is already under the safeguarding system, for everyone to find little wrinkles, problems, a marital breakup here, a period of depression there, that means that this is the reason why the child has these behavioural problems. And it's intensely blaming the families, and it's also scientifically really not very rigorous, because how many mothers get depressed? How many marriages break up? The question is always, well, why is this child exhibiting this behaviour now? And that kind of blanket, oh, it's all attachments, it's just to do with, parenting, the parenting has been deficient in the past. What you do here is exceptionally unhelpful, because again, none of these approaches give you the possibility and hold out the possibility of change and improvement, in my view. What I would prefer, and the other thing about them is that they all blame. So the doctors will blame biology, the parents, the schools might blame the parents, and of course, so might the kind of attachment slash early parenting narrative, all point the finger of blame. And I think the finger of blame is absolutely what we need to avoid and move away from if we're trying to analyse behaviour. It's absolutely completely unhelpful to talk about blame or fault. For me, the task here is to identify where we are, how we got here, but more importantly, where we go next. So to take the child and the family by the hand and make small incremental improvements to move them forward. And I think, some medical aspects and some disciplinary aspects and some looking at the background can be helpful along that line, but it should all be filtered through how we're going to move this forward, how we're going to make things incrementally better. And it's a difficult thing to address as a doctor, because what we're used to is symptoms, diagnosis, treatment, bang. But this isn't like that. And the other thing that makes these, so it's a hard It's a common condition which is hard and complex, and we don't have a setup for it. So that makes it hard already. But then, of course, you have the difficulty that these conversations themselves are hard. And I think there's several reasons for this. One is that it's inevitably parents feel blamed. Because often it's been hinted to them, or it's been kind of suggested to them that the reason why their child is behaving in this way is because in some way they are deficient, either in the past or currently, in their parenting. And for those of you who are parents will know that actually it is very, very hard to hear that you've done this wrong, this thing that you're so invested in. The fact that it's gone wrong and you've done it wrong is incredibly painful. And of course, it's a very common reaction when you feel that you're being told that you're doing something wrong to become defensive. And in fact, it's very difficult not to be defensive when you're being told something so important. And this, of course, will make them resistant to help. So one of the conversations I'm going to talk about in a minute is the conversation about parenting programs, which is often a very difficult one. And the other thing that makes it hard is that dealing with these behavioural difficulties is hard work. It's hard work for you, it's hard work for them, and the results are not certain by any means. Sometimes it doesn't work, sometimes you can't make progress, sometimes you get stuck. And so the conversations can feel a bit hopeless. And I think my purpose in this hour is to try and make them feel a bit less hopeless, so that you can feel like you're making small incremental improvements. And one of the things that I would say first is one of the things that I get anxious about when we're talking about behaviour is expectations. Having expectations that you're going to sort it out. So the family might place those expectations on you, and you might place those expectations on yourself. And I think subconsciously, when you're getting into a discussion about behaviour, thinking, I cannot fix this, but there is a possibility that I can make things a little bit better. That is the way to approach these conversations. And being honest with families is often really very helpful at this point. Say, this is going to be really hard work. We don't know if it's going to work, and we can't fix it completely. Being very upfront about that early on is ultimately going to be helpful. So the one question, the sort of implicit question that often people kind of ask in clinic when we talk about parenting is, well, why on earth do I need parenting support? Because I'm a good parent. So they may have had 3 or 4 other children who've been fine, and then there's this one who is problematic, or they may work in childcare, and we'll say, well, what's wrong with me? And I understand that, and it's a difficult conversation to have. So this is the sort of conversation, and you can put it in your own terms. But let's say you're all sitting in exam, you and your mates are all sitting in exam. This is a familiar picture, I'm sure, to all of you. And you discover halfway through the exam that the middle row, the middle column, have a pass mark of 60%. If they get more than 60%, they're fine, they've passed. But your column, arbitrarily, have been given a pass mark of 90%. That's what it feels like to have a child, for whatever reason, who is more difficult to parent. So they may have been traumatized. They may have an additional diagnosis such as ADHD or ASD. They may just simply have got into a pattern where things are very, very difficult and they're getting very angry about things. That means that your pass mark for parenting is 90%. And I think it's really useful in just sort of, you don't necessarily have to talk about exams, but you can just sort of say, most people are 60% parents most of the time. And you can say, I'm a 60% good parent most of the time. And that's fine for most children. The problem with the child we're dealing with here is that you need to be at 90%. And so what we do when we offer parenting is that we're trying to bring you from 60 to 90%. And of course, you can, and I don't always, but there are some people who can get away with being 30% good parents, and their kids are still fine. And that's it's deeply unfair. But what's the alternative? I find the 60 to 90 conversation really, really helpful, and I think it does help people to feel less blamed. So the other thing that we have to do when we're setting our expectations is think about to ourselves, what is it that we can and can't do for these families? I think what we can do is put together a picture of the child and identify underlying conditions And it can be something relatively complex like an autistic spectrum disorder that can take a while to diagnose, or it can simply be the fact that you're the person who thinks, well, maybe we should get his hearing tested, or you know, his sleep isn't very good, maybe we should just get him to a sleep workshop, or we should just sort of have a chat about that. It can be really, really simple things, or it can be really complex things, but it's just identification of underlying factors can be a vital part of our role. The second thing that we can do, and I hope some of you at least have seen one of these grids. I don't insist that we use them all the time, but it's a good mental model for how to, what we call, formulate. So to take the factors underlying a particular behaviour or a particular symptom and put them into an order for yourself so that you can plan intervention. I'll go into that in more detail in a minute. And the third thing that we can do is engage. This is, of course, engagement ring. So we can use that kind of 60 to 90 or other conversations to engage them in intervention that you think is going to be helpful. And you can be confident that it's going to be helpful because there's a really good evidence-based, irrespective of the underlying cause of behavioural difficulties, that a group parenting intervention over 8 to 12 weeks, facilitated by professionals, is an effective intervention for oppositional defiant behaviour. And there's very good RCT evidence for that. So when you're engaging them in a parenting group, you're not just kind of being nice, you're delivering and facilitating delivery of an evidence-based treatment. And you've got to be absolutely clear about that with families. This is the thing that we cannot do. We cannot actually run parenting classes. We cannot see people, you know, very frequently and talk through their difficulties and give advice, because actually, for two reasons. One is we just can't, and we don't have capacity, and we shouldn't be offering that. And the second is, actually, if you actually go to a parenting group, and I do recommend, if you can, that you do. It's not actually advice given by the facilitator. The thing that people learn from is the conversation within the group. The magic of these things is the group. One-to-one parenting interventions actually don't have the evidence base that group parent interventions do. And so group interventions are both have a better evidence base, but also are more cost effective. So it's a no-brainer. It's one of the most cost-effective interventions in all of medicine, probably. And the other thing we can't do, and we all do it, is take on the burden themselves. Sometimes these families come in and they want someone to take the burden. They want someone to take on all of the housing problems, take on all of the school being beastly to us, take on all of the stuff that the family are carrying around. And of course you can sympathise with their burden, but you can't take it on. And I think one of the things that really puts particularly trainees off this kind of work is the feeling that you are essentially just taking things from the family and basically taking a lot of work from them. And you shouldn't do that. You can help as a professional and you can facilitate and you can signpost, but you can't take on the burden. You can't, because actually it's their burden, and unless as I say, unless they parent their child, no one else is going to do it for them. So you have to have a shared understanding. It's all very well for you to do something clever and work out why you think this child's behaving like it is. But you not only have to explain it, you have to get them to own it. So if they have some stuff that you're not sure about that they think is true about why their behaviour is, you can correct it, you can talk about it, but they've got to in some sense own it. One of the things that frustrates me a lot about CAMS, about the Child and Adolescent Mental Health Service, is a tendency to have really clever formulations. They don't actually tell the parents. So the parents are left very isolated, and they just feel like things are happening to them rather than with them. So of course, in order to do that, they need to understand why there's a connection between the way that they parent and how the child is behaving. So that's what we're going to cover in a minute. And I put SMART objectives as a sort of as a bit of a wink to management, but you know, there's nothing wrong, because if our objectives needs to be SMART in an organisation, why don't they need to be SMART within the family? So it's having objectives that are measurable. So, you know, not just being good, but not kicking your sister. It is sort of, you know, you've just got to be things that are achievable and that you can come back and say, well, has that happened? Why not? What's going on? These consultations are difficult, and I was interested to note that in your learning resource, there's a book I've never heard of before called 10 Minutes for the Family, and that probably is something that we should have a look at some point. But I think there are some specific consultation issues that we can take from people like CAMS, albeit that they're frustrating, and we can use some of the tricks that they use and some of the focus that they have on the interactions within the room to our benefit. So modeling listening, modeling, letting everyone having a say is really powerful, and also boundaries. So if the child is misbehaving in your clinic, it's absolutely fine to put boundaries in place, because then you are modeling a kind of role model of, calm, authoritative parenting. You must be prepared to split them up, particularly with older children, so that they can have their say, and also so the family can have their say about the child. There's really nothing worse, both because it's upsetting, but also because it's completely diagnostically hopeless, than just having a litany of how awful their child is, kind of regaled to you. So when you have that situation, of course, splitting up is one solution, but actually the litany is itself boring and unhelpful. So why try and get some positivity, get in early with things positive. Within the first couple of minutes, I'm asking the child what they enjoy doing and what's fun about home. And then, of course, you get both verbal and non-verbal clues that all is not well, but equally they will often, kind of start the consultation in a better frame. And then when you start getting these kind of, he's awful, he's terrible, I can't cope, you have to basically then go, okay, fine, tell me what happens when you go to the supermarket, tell me what happens when you go to bed, tell me what happens when you have a meal together, and then just keep it factual, because then you will think, oh, hang on, something not happening there that perhaps should happen. And because then you're sort of talking about, well, what are the chains of consequence? What are the chains of events, the patterns that people have got into? And we'll talk about that a bit later, how those patterns emerge and how they can be hard to shake. So there is this kind of slight friction, if you work in mental health for a long time, between people who want to formulate and people who want to diagnose. And actually that's completely unnecessary friction. It's perfectly possible to do both. So for me, the question of whether you should be finding a cause for the behaviour doesn't really make sense, because there's never a cause. There are things that will be contributing to the behaviour, but there's never a single thing. So just to take an analogy, if you were to ask how the First World War occurred, you could either ask a historian, to outline this very complex nexus of causes and fascinating story, or you can just say some bloke shot a bloke in Sarajevo, and we're all clear which is the more illuminating and interesting and ultimately useful explanation for that event. So the same is true here. We can't just focus on single causes. So then the question is, so how do children evolve into patterns of disruptive behaviour? And I'll come back to this in a minute when we talk about how to formulate, but what they form is these negative working models. So we all have in our lives working models of how to respond. So someone comes into your office, you're smiling before you know it, because you have an expectation of a positive interaction. Hopefully, you come home and you're already in a kind of expecting a positive interaction. Hopefully, again, but what if your expectations are that you're going to get a negative interaction? What if your working model is that it's unsafe? Is at some level it's unsafe to be in an argument, or it's unsafe to be challenged. All of those working models are all around us, and one of the most prominent ones, of course, is the attachment system, which is very important in conditioning your response to threat. So will you seek proximity? Will you be comforted by that proximity? So all of those things are really important, and they all condition how you respond to perfectly normal things. So they often condition, how they respond to frustration, particularly. how they have responded, how frustrating situations have happened before will get them into situations where they get stuck in negative behaviours. And the other thing that will get them stuck is, so if they're consistently frustrated, either by not getting their way, or by not being able to communicate, or by other people's behaviour, then that will often breed this behaviour, breed disruptive behaviour. Inconsistency between parents or within a single parent over time leaves the child feeling confused, and therefore has a sort of higher emotional temperature, in a sense, or their regulation of emotion is lesser. And so therefore they're more likely to blow up, particularly if they don't know what's going to happen, if the consequences, so kind of negative consequences for negative behaviour, if they're not consistent, the child may well persist with the negative behaviour. So consistency is key. A lack of control by the parent is really important. So if the parent doesn't feel in control, then they are not going to feel able to apply parenting. And also, if the child feels that adults are not in control, that will make them stressed. Even if they're appearing controlling themselves, they are going to be calmer if the parent is in control. And what the significance of neurodevelopmental disorders that we'll briefly touch on is that they narrow your margin for error. So if you have a diagnosis of autism and you are becoming frustrated, there's a very narrow margin until that turns into a meltdown, because of the barriers of communication, because of the often rigidity of thought, but also because it may be that this child has quite negative ongoing relationships, has received negative responses in the past. So it's a fact that they give you no margin of error that makes the neurodevelopmental disorders really key in thinking about diagnosis. If you don't understand anything, please put things in chat. I know I'm rattling through, but I want to have some time for questions and discussion. So what you need to do is formulate and co-author an idea. You don't have to do one of these, but you need to come up with a story. And you can actually, one of the nice things about a developmental assessment or something is that you don't have to make a diagnosis in the first pass. I would encourage you not to, but what you can do is actually come up with a story as to why things are happening. So if you come up with this young man that I saw years ago now, who's got a paternal history of criminality, he's 7 years old, he's in year 2, and it's just starting to emerge that he has special educational needs. He seems to have an impulsive response to stress, so I'm thinking whether there's an impulsivity, but on the other hand, he has good social skills. So this column, which is a biological developmental column, is sort of going through from previous things that have happened, things that are precipitating the current referrals, the things that are making things, they're trapping him into vicious cycles, and the things that are making things not as bad as they could be. And what we often do is we kind of reasonably good often at these, kind of past medical history, and then why things are happening, and then why things are remaining bad. But we're not good enough as doctors at looking at this stuff, because actually when it comes to actually using this to manage behaviour, the bottom two are the key. The bottom 2 rows are the key. But just to quickly go through, the psychological one is a bit more tricky to fill in, but this is to do with you don't have to be a psychologist. You don't have to pretend to be a psychologist. It's just how are his thoughts and emotions driving some of these behaviours? So is the fact that he's aware of his falling behind driving some of his behaviours? Is the fact that he's having lots of negative attribution, so lots of negative things being said about him that he is then thinking about himself? Is that having an effect? Because he is also having some quite harsh and critical parenting from his teenage mum, who is also struggling economically. But again, positivity. Mum is trying to get herself back on her feet. He has positive relationships with other family members. So that's just a very simple thing. The way you can make it useful is basically, in a sense, to draw a red line here under precipitating and say, okay, those are the things that have happened. Here are the things that we can do something about. And really, the management, as well as optimizing parenting, which we'll talk about in a bit, is to basically to look at, well, what are the things that we can dial down here and what are the things that we can dial up here. So take this child as an example. You use his good social skills to give him more responsibility in school, so he feels better about himself at school. You talk to school about his impulsivity and how they can manage that better. You get mum to take a more positive parenting role, and you encourage the relationships that he is having and spending more time, in this case, with his uncle. And then, of course, we write letters of support to mum, to her college, to say, she's struggling, but we really think this will help her. And actually, Aidan did rather well. He did get a diagnosis of ADHD, but actually, the useful things that we did is all the other stuff. So the thing that people struggle with sometimes when they're trying to formulate is what goes into the psychology bit. And so this is almost kind of clinical psychology in one slide, which is a ridiculous thing to attempt. But there you are. All behaviours go through this cycle, don't they? So you have a stimulus of some kind, and that causes an emotion, and then the behaviour results. And that's true of positive. If you're giving someone a hug, you have the kind of them wanting a hug, you feeling like giving them a hug, you give them a hug. So it's not just negative behaviours. But the point I want to make is when you're talking about children, and actually true of all of us, but the emotions aren't necessarily I want to do this or I am worried about this. It is much more basic, and it's often unspoken. So you often need to kind of guess at what the behaviours are from the behaviour, the emotions are from the behaviour. And the other complication is that you have the impact of previous similar experiences. So I think a lot of the time when children have been have witnessed domestic violence, any kind of confrontation will tend to be regarded as potentially violent, and they will respond accordingly, often with violence themselves. And then how they expect people to respond to their behaviour. So if they think I can get away with this, then of course they will. Equally, if they think that if they get angry or if they show emotion, then people will kind of be negative towards them. Actually, paradoxically, that can make things worse because they're desperately trying to contain their emotion because they don't feel safe having emotions outwardly, and then their emotions will come out in violence or aggression rather than in sadness or worry, if that makes sense. And then, of course, there is the cognitive aspect of things. So children with learning difficulties, learning disability, children with language disorders, children with autism, do find it harder to understand what's going on emotionally, what the social cues are. And then, of course, and this is connected with the attachment thing we were talking about earlier, as you grow up, if you have a kind of stable emotional upbringing, and you have a family and a group of people around you who encourage your ability to reflect and to think about your own feelings, that will help you to control your emotions over time. And so that connects in with your ability to emotionally regulate. It's not the only thing, though, because you're tired, your degree of tiredness, whether you're ill, whether you're hungry, all of those things and whether you have ADHD, will interfere with your ability to regulate your emotions. So you could put so many arrows in this diagram, but I chose to keep it nice and clean. But just to say, those are all impacting into the emotional stew. So it's unsurprising that as a sort of paediatrician, we sort of think, well, this is all too much. But actually, everything is quite straightforward individually, and you all understand that people have different degrees of ability to reflect on things. You all understand that the expectation of what will happen when you do something is going to affect what you do. It's just a question of drawing that understanding out yourselves and thinking about it with families if you can. So people often think, well, okay, fine, this is fine, but isn't it much easier just to say, okay, he's got ADHD, this is why he's behaving this way, let's treat that. And I think there's an element of truth to that. So I put up lots of acronyms because I think it's hilarious how many we've got. So we've got oppositional defiant disorder, general anxiety disorder, pervasive demand avoidance, reactive attachment disorder. I can't even remember what that one is. And social engagement disorder. Sorry, I can't remember what that one is. And the point of bringing them up is that, yes, we're very clever and we can give people acronyms, but the only thing that they act on is as a backdrop to behaviour. You do not hit your brother because you have ADHD. You hit your brother because he is annoying and you find it difficult to control your frustration and anger with him. Now, the ADHD is in there, but if your brother was not annoying, you would not hit him. Now, I'm not saying you should hit your brother, but you understand the point I'm making. So it only acts as a backdrop. Treating the underlying condition, if indeed we can treat the underlying condition, will only change the backdrop. It won't change what is happening. If you have an abusive parent or an abusive partner of your mother, that is still going to be a problem if you treat his, if you treat his anxiety, this child's anxiety, which is why a purely treatment-based model isn't actually going to be the best one, because it's a dead end. If you treat things and you give your treatment and it doesn't work, it doesn't make things better, you shrug, go, sorry, didn't respond to treatment, off you go. And that is not in the best interest of the family. As paediatricians, I think what's really strong about our profession is that we don't let go of people when the first thing we try doesn't work, and other people do. And the other thing we must never say, I've sent an email this morning from a very good, very experienced paediatrician that many of you know, saying this behaviour, this thing he does is not medical, it's behavioural. And I didn't, but I could have said, well, that isn't helpful. So if you were to say someone's got a cough and someone says, well, I don't think it's a pneumonia, I think it's respiratory. And people would say, well, that's a weird thing to say because it doesn't tell you anything. And so to say that a behaviour is behavioural is basically saying nothing. Now, if you want to say, I don't know why this behaviour is happening and I don't have time to think about it, that's okay, but you have to be honest about that it's beyond me to think about it. I hope I've demonstrated in the last few minutes, it's not beyond any of us to think about why behaviours might be happening and to actually have a bit of a conversation with people as to why they might be happening. So that's the first sort of part. The second part is much shorter, I promise. This is basically how to parent in a very short period of time. There are basically, parenting is a billion-dollar industry, but really it boils down to 5 principles, one of which most of the parents, most of the parenting books and courses don't even talk about. So here you go, extra super value from the next 10 minutes or so. So this is not obviously what I thought was a funny thing, but obviously I don't advocate scaring your children. I think the first thing is modeling all of these things in your relationships. So modeling positivity, responsivity, structure, consistency, and patience in your relationship with your partner, or your relationship with your friends, or your relationship with other adults generally is a really important part of this. So what do I mean by positivity? I do not mean this. I do not mean the kind of toxic positivity in a way of everything's great, isn't it great? I'm living my best life. That isn't helpful for children anyway. What is helpful is specific positivity about specific things. So I really like the way you did that. I really like the way you shouted at your sister but you didn't punch her in the face. That sort of thing. I really like the way I really like the picture that you drew. I think the unicorn was particularly fine. That sort of thing is much more helpful than general praise. And the other thing is what they teach in the parenting course classes, and they spend about the first 2 weeks on it, is spending time doing things that your child wants to do with them. And people get very worked up about, well, all they want to be is on the PlayStation. Fine, join them. It's fine, it's absolutely fine. You can have positive group time with your children, losing horribly to them at Mario Kart. It's absolutely a valid way of saying it. It doesn't have to be a pleasant walk, a lovely walk in the woods and a kind of building a den. It can be modern technological things. It's absolutely fine. So the second thing is responsivity. So this is a slightly parent-blaming image, but I think one of the things, what we're not saying is that you have to be at your children's beck and call, but I think it is true that, and there's some recent data on this, a paper out this week, it isn't that you have to leave your phone in your pocket whenever you're with your children, but if you are spending a prolonged time on your phone when you are with them, then they will, your responsivity to their behaviour will go down, and they will tend to exhibit more disruptive behaviours. So it isn't a problem for you to check your email, but it may be a problem to endlessly scroll Facebook for an hour while you are looking after them, potentially. But of course, then you have, well, who are the people who are scrolling endlessly? Are they actually, feeling a bit depressed and a bit isolated? Are they what are they trying to avoid? So it isn't even just change this. It is thinking about, well, why is the parent to an extent withdrawing, and why are they not engaging with their child? But not, that said, being responsive to your child and catching them being good is really, really important. So if you have a family and say, oh, God, when's the last time, tell me something he's really good at, something good he did that was really good. And if they can't say anything, they really are onto a loser. Every single child, you can catch them doing something good. And there's no child who doesn't ever behave better than they could have done. You often have to have a very, very, very low threshold and a very, very low standards in order to count as good. But you've got to start somewhere. Start from where you are, like I said. So structure, this was an area at the beginning of the lockdown, all the kind of daily schedules that people were coming up with when the children were going into lockdown, and then sort of everything was kind of everything was kind of well, this was kind of the reality, at least in our house. It was basically a bit of a free-for-all. But the point is that some kind of structure is really important. So you don't have to do this, but what you can do is say, okay, we're going to wake up at a particular time. This is when lunch is. You have to do X amount of stuff in the day. I want you to tidy your room, and then we can have, we're going to have dinner at this time, and you go to bed at that time. That's the sort of structure I mean. But also, you've got to plan ahead. One of the things that people don't do when they have behavioural difficulties is they don't plan ahead. And so, if people tell you, well, it's awful going to the supermarket with them, ask them, well, what do you do in the car park? What do you say? What's the conversation you have with your child in the car park before you go in? And often they look at you very blankly. And the third thing is to have a structure in terms of fighting your battles. This is probably not a true Sun Tzu quote, but I think if you don't, you've got to be clear that you're going to win before you fight, and determined to win before you pick something up. So that's when you're picking out what behaviours you want to address and how. You've got to think, okay, one or two behaviours with very, very clear, with very, very clear consequences. Otherwise, you're on a hiding to nothing. Nearly there. You've got to be consistent. So it is consistency both yourself. So the person who's in charge is not you, stressed, tired, 8:30 on a Monday morning when they're already late for school and you're trying to get them to get the shoes on. That's not the person who's in charge. The person who's in charge is the person who wrote, with a cup of tea, calmly in the evening, wrote out the plan. And that's still you, but it's the calm you that's in charge. And the other thing is consistency across different carers, really also very important. We're going to move on. The final thing about parenting, which is really so important, and doesn't make it into the books because the books are selling a quick fix, is it will get worse before you get better. If you put in place, against the background of children who are exhibiting negative cycles of behaviour, you put in place the correct management, the boundaries, you put in place consistency, structure, their behaviour will likely get worse before it gets better. And no one says that to families. And the other thing is we don't know how long it will take to get better, but we do know it will get better. This is not to do with children's behaviour. It's an extinction burst from an animal experiment, but about another sort of behaviour. But the extinction burst is real, and the problem is if you just give some advice and you don't tell them this, they will get to this point and say, well, that doctor didn't know what they were talking about, and then they will stop your advice and they will never move forward. So Yoda is right. You must have patience. So what I'm saying then is that you should be trying to troubleshoot specific problems. I think that's a valid thing for you to be doing. rather than trying to fix the behaviour all around. The formulation was relevant, and I went into detail about it for a reason, because you can improve the context in which the parenting is occurring. Also, you obviously need to engage with other people, discuss realistic parenting goals, that's the SMART objectives I talked about, and then agree a specific plan. If you can't follow that plan up, think about who can. Is it the school? Is it the health visitor? Is it another parent? Is it a parenting group? Just a one-off isn't necessarily going to change behaviours. And I think the thing that just the final kind of talky bit before I take some questions is, I like to put Doctor Who in at the end, but I think there is always hope. Sometimes these can feel like the most hopeless cases that you just want to run away from. But actually there is always something that we can do. I think I can't remember the last time I came away from a discussion with a family and there was nothing that we can do to at least make things a little bit better. So that's what I wanted to say. I'm sorry, I've taken more time than I wanted to. I need to redo some of the slides to make it got a bit bogged down in the middle. But I'm going to turn my camera on so people can see me, and I'm very happy to take questions in the chat. I know there's been a lot of information, and I think I'm going to close the slides and just wait to see if anyone wants to put any questions in. If anyone wants to unmute and ask a question verbally, that's also fine. Okay. Sun silence. Okay.
I've got a question, if that's okay.
Yeah.
So I found with some parents, they're very fixated on this idea that there's something wrong with their child, and very blaming of the child for their behaviour. I really liked your kind of 30, 60, 90 approach to kind of explaining that. But are there ever some families where maybe you avoid that if they're very this child is, they're difficult, they're different, they're bad?
I don't think so. I think the 60-90 approach can still be used. Yeah. Because I think because what you can, so you've said those three things. You said they're difficult, they're different, they're bad. And I think you can certainly say yes. And I mean, we need to look into what the differences are. And part of our role is, of course, is if people think that there are significant, particular differences in their child, that's the core task of a developmental assessment. If they say that they're difficult, you can acknowledge that the relationship is difficult and the job that the family are doing is difficult, but that's different to the child being inherently difficult. And then you can reject outright the idea that this child or any child is bad.
Yeah. Thank you.
Hi, Max. Hi. Can I ask a question?
Sure.
Hi. I missed the start. Apologies for that. I was very interested in your use of a mobile phone, and just wondering if we're sat on an epidemic of attachment disorders coming 5, 10, 20 years down the line.
No, I don't think we are. I think actually people did look at attachment and phone use, and there is a very small effect with prolonged phone use on attachment style. I have to admit I'm skeptical of the overuse of attachment disorders in certain services as a kind of catch-all for relationship disorders, for relationship difficulties. So it sort of depends. So will we get an epidemic of people being diagnosed with attachment disorder, well, possibly, but I think that using your phone when you are around children is not necessarily going to cause difficulties with your relationship with them. I think it's to do with how you use your phone when you're with them, and I think that the evidence from the recent really very good study is that it's being continuously for a prolonged period on your phone and therefore not responsive. That is problematic. Now, there are people, of course, who do that, but again, as I said, if someone is doing that, then we need to think about why. What is it that's keeping them? Keeping them from avoiding their. Why are they avoiding contact with their children, and what is it that's kind of so difficult for them about doing that? If that makes sense.
It does. I've not seen the study that you're referring to. I was just looking through the 5.
Go on.
Sorry, the 5 principles of parenting you went through, and particularly the responsivity point. Use of mobile phones would impact massively at meal times, in free time, anytime during home life.
Well, to an extent, yes, but I think that so I have been concerned about this, but the recent data suggests that. So, for instance, if you are at dinner and you receive a text and you answer that text, and then you go back to interacting with your child, that's really not a problem at all. If you are and actually, one of the things that they found is that if there's a fairly brief period of continuous engagement with phones, then very often the parents do a sort of compensatory super engagement afterwards. Do you see what I mean? So they'll kind of go, oh yeah, I've been on my phone, and then really spend some time with them after that. So I'm not massively worried about mobile phones. I mean, my personal, I don't like having them at meal times on the table or around, but of course, if you get an important message or something, it doesn't really particularly matter if people want to answer it. So yes, and so I guess yes and no. I mean, people have got to manage within what they're capable of doing. Ideally, I think meal times it would be good to have meal times as a screen-free time, but I think if that's not achievable by families, I don't think we should be pathologizing that. I think we should again be going from where they are incrementally in small steps towards where perhaps we'd like them to be.
Hi, Dr. Max. I'm Nori.
Hi.
Thank you very much for such a good and informative talk. I am one of the neurodisability sprint trainees. Can you kindly point out some sources where I can learn more how to help the families managing this behavior and reading about these things?
So your learning pack has some useful links, a couple of which written by me, but a couple of which not written by me, under the section, I think, marked attachment and helping families. So I think those were very well put together by Catherine Sikorsky, I think. And I think I think a lot of this is experiential learning. It's just working with families, having ideally families that you see several times, and just sort of see what works and what doesn't, and then discussing with your sort of supervisors, how things have gone. I do think that attending in some respects or in some capacity a parenting course is a really, really valuable experience if you can possibly manage it. But I appreciate that that's quite difficult to do.
Sure. Thank you very much.
Max, I have one quick question, if I may. It's quite a specific one. Can you hear me okay?
Yeah.
Good. So in the context of a clinical encounter, this is something that you and Emma both sort of briefly mentioned, the situation in which a parent is sort of talking a lot about how the child is bad or how difficult it is to cope, and obviously it comes from a place of difficulty in not coping, but the sort of verbalization of that is about the child being bad and impossible to deal with. And often my instinct in that moment is to perhaps defend the child or to try to counter that, because that's, you know, my sort of emotional response to that. But I recognize that risks not acknowledging and validating the feelings of the parent. And I guess my question is, how does one strike a balance between acknowledging and recognizing the difficulties the parent's facing at the same time as protecting the child in that potentially toxic discussion, and also sort of trying to, you know, see positive and move forward therapeutically, I guess?
Yeah, so I mean, I think part of that is preventing that conversation in the first place. And so I will always start with a conversation with the child, which is, you know, and it, for the first few minutes, focused on the things that they like and the things that are fun and the things that they're good at. So at least that puts a little bit in the bank as in terms of this being a positive interaction. And then, you know, I don't necessarily always sort of ask the parents, you know, the classic question. So, you know, what, you know, how are things going? What are you worried about? I might say, you know, how are things day to day? Tell me about that. Because the quicker you can get from judgment court, you know, judging the child and offloading their emotional state to describing the behavior of the child, the more you'll get to solutions and the more you'll get diagnostically useful information. But yeah, you're right. Sometimes you do have to try and find somebody who will keep an eye on the child while the parent needs to have a cry. And you do need to sometimes split them up. But I completely agree with you that listening to this litany of complaints about a child is only going to be unhelpful. And probably the child will absolutely, you know, lose it afterwards, and quite possibly punch everyone in the house if they've been through that experience in front of you.
Thank you, very helpful.
I have to say, it doesn't happen in my clinic. I don't really know why, but I think some of the tricks I use, just trying to stay really positive throughout, seem to kind of put it off, or maybe, I don't know. I just don't get it that much.
Hi, is it possible to get these slides, Max?
I'm sure it is. I don't know who I could send them to.
Will they be put online somewhere, or has this been recorded?
I can send them to Emma, or...
Yeah, feel free to send them to me. The session's been recorded and will be uploaded to the London School of Paediatrics YouTube channel. And then I think what I can probably do is to put the talks links to the talks within the timetable, but that just might take me a week or so to work out how exactly to do that. But if you keep an eye on the London Paediatrics online section, then yeah, we can do that.
Perfect, thanks.
Great. Fab.
Okay, 2 o'clock. I have another meeting to go to. Unless there's any burning questions, I will say goodbye, and thank you very much for listening.
No, thank you so much for the great talk. If everyone could fill in the feedback form that is just in the chat bar, we'd really appreciate it. Thank you.
Bye.
Thanks, bye.